Hello, this is Marian Gandy, Assistant Director of Provider Education at the Association of Community Cancer Centers. I want to thank you for joining us in today's webinar, Molecular Testing, the Tissue Issue, Sampling and Testing, as part of the Molecular Testing Peer-to-Peer webinar series. Funding and support for this series was provided by Pfizer Oncology. This webinar will be presented by Joe Kim and will feature Gail Probst, the Director of Cancer Services at Huntington Hospital's Don Monte Cancer Center. Gail has been serving as the Coordinator and then Director of Cancer Services for over 25 years. Dr. Kim is President of Medical Communications Media. Over the past several years, he has worked to support process improvement on various ACCC education initiatives. His work focused on biomarker testing has been published in the ACCC's journal, Oncology Issues. At this time, I will turn the session over to Dr. Kim.
To start the webinar today, we're actually going to talk about a project that kicked off in 2014, which included the involvement of 8 community cancer programs, all part of ACCC's membership. And this was a collaboration that was supported by Pfizer with the intent of improving biomarker testing in patients with advanced non-small cell lung cancer. Each of the 8 centers reviewed their testing processes and actually looked at data from their cancer registries and extracted records from their health records as well as pathology reports. And then after we collected that baseline information, we actually spent 2 hours at each of those programs on site with their entire interdisciplinary team conducting a learning lab and really just talking through their processes, looking for opportunities for improvement, engaging key stakeholders, and identifying what kinds of changes would ultimately lead to the most improvement. Each center committed to making some improvements based on the collective group's feedback. And then from there, they filled out a Plan, Do, Study, Act, or PDSA Cycle for Improvement document so that they could actually set some goals and track their changes and progress over time to see how biomarker testing would improve for their patients with advanced lung cancer. Here are the 8 centers that participated in this program. You'll see that they are all different sizes. They are all around the country. And it was really an opportunity to see that across all of these 8 centers, their molecular testing processes or methods, even the number of lung cancer patients that they're treating, tremendously varied. And so we found that after going to 8 of these programs, really you cannot take a one-size-fits-all approach. You really have to customize it based on the dynamics of each program, their staffing resources, their staffing dynamics, as well as their patient population and other resources that they have. If we take a step back and say, all right, well, if we were to de-identify these 8 programs and look at what are their baseline molecular testing rates for patients who have advanced stage 4 lung cancer, and if we look specifically at EGFR and ALK testing rates, you will see that we've categorized these 8 centers into those who treat over 100 lung cancer patients a year, as well as those who treat less than 100 patients with lung adenocarcinoma. For those that treated over 100, on average, their EGFR testing rate at the beginning of this program was 62%, and that was an average. Some were as low as 38%. And then those who were testing for ALK ranged on average 60%. So we found that there was definitely room for improvement because these are the patients who ultimately, with this appropriate biomarker testing, depending on the results, could benefit potentially from new therapies. If we look at the programs that were treating less than 100 lung adenocarcinoma patients a year, we saw that on average those EGFR and ALK testing rates were lower, 52% for EGFR and 47% for ALK. So once again, clearly some opportunities for improvement. We presented their own data to each of the centers and showed them based on their own performance that this was how they were doing in that sort of 2012-2013 time frame. And then we challenged each of the groups and asked them, you know, what should these numbers be and how can we ultimately get them to a higher percentage? So the objective today is to really talk about how oncologists, cancer programs, really the entire interdisciplinary team of the patients and treating patients with advanced lung cancer, you know, how can they ultimately form policies, procedures, standard operating processes, and get buy-in with the appropriate leadership and direction at each of their programs to improve biomarker testing for patients with advanced lung cancer. And understanding that, of course, it's dependent on the quantity and the quality of tissue that we get from the biopsies, but it's also dependent largely on the actual process of once that pathologist receives a tissue and then the kind of communication that goes back and forth with the different clinicians, as well as the expectations from the medical oncologists when these biopsies are being performed. So it's really our hope today to talk through some of these things, and we'll be interacting, and Gail will be sharing insights from her program. And it's our hope that you all, as you listen and interact with us, will have the opportunity to think about your own program, your own staff of clinicians, as well as the dynamics that are occurring within your own center to see what could potentially change, what could be improved. Now, just to set a little bit of background, 2013, the College of American Pathologists, or CAP, the International Association for the Study of Lung Cancer, IASLC, and the Association for Molecular Pathology, or AMP, released the guidelines. These were the first set of sort of formal, established, comprehensive guidelines titled Molecular Testing Guidelines for the Selection of Lung Cancer Patients for EGFR and ALK tyrosine kinase inhibitors. And EGFR and ALK currently are the two biomarkers where there are FDA-approved therapies, and hence in 2013, these guidelines really were applicable because these were the actionable mutations that could really guide clinical treatment decisions. In January of this year, these three organizations, CAP, IASLC, and AMP, announced their plans that they are going to have to update these guidelines. There's been a lot of evolving science, and they've commented in a press release that they need to address issues dealing with ALK testing recommendations, as well as EGFR and ALK resistance issues that are coming up, the role of emerging molecular targets, and the need for rebiopsy and repeat analysis, especially when patients relapse. So I think it's fair to say that probably either later this year, sometime next year, we're going to start hearing more about these updates. Meanwhile, at large cancer conferences and different publications, we're continuing to see emerging research and data on all of these issues, and hence all the different oncology clinicians in the community need to understand how to apply these things in their practice. Now, we know that non-small cell lung cancer is a heterogeneous disease. It is not just a single type of cancer. And if we look at the history of our understanding since the late 80s, when really at that time we knew about certain mutations, especially given that we were finding them in other sites in the body. For instance, we knew about hormone biomarkers in breast cancer as well as colon cancer, that in 1987 really we were familiar with KRAS, but we didn't really do much with that information. Then in 2004, sort of if we fast forward, we discovered EGFR. But of course, we also knew that the scientific community knew that there was this large other proportion of patients with advanced lung cancer who have this unknown mutation. Fast forward to 2013, and we see that there are a host of biomarkers that we know are these genetic mutations that ultimately contribute to the cause of lung cancer, specifically KRAS, EGFR, ALK, and then there's a host of others. And so every year, this pie chart continues to evolve. Every publication, I think, continues to explore exactly what are these rates and what are the rates in different patient populations, and ultimately, how can we use this information to treat this disease and to improve clinical outcomes. So just going back to those CAP, IASLC, and AMP guidelines, there were just a few things that we really drilled into when we went to these 8 cancer programs and conducted these learning labs. Specifically, we wanted to ask questions on what their processes entailed as it relates specifically to some of these guideline recommendations. So for instance, in Section 1, Question 2 of the guidelines, in 2013 guidelines, there's a question that says, when should a patient specimen be tested for EGFR mutation or ALK rearrangement? The recommendation was that it should be ordered at the time of diagnosis with those with stage 4 disease. there's also a suggestion that it could be ordered at the time of diagnosis for patients presenting with advanced stage who are suitable for therapy or at any time of recurrence. And then another recommendation that tissue should be prioritized for EGFR and ALK testing. And we were asking these programs, are you actually applying this, or are there deviations from these guideline recommendations within your practice? We spent a lot of time discussing how they were prioritizing lung tissue when it's biopsied, who was making decisions on the different molecular mutation markers that they were then going to test for. Were they prioritizing it for EGFR and ALK? Were they testing it for other things? What was their process? Were they testing for both of these mutations simultaneously, or were they testing for one followed by the other? And what we found across 8 centers was that there was a lot of heterogeneity in terms of how they were following these guidelines. So a key barrier and an issue that seems to be a common theme that comes up over and over across these cancer programs, whether they're large programs or small to medium-sized programs, is that often the biopsy tissue samples are very insufficient. If the clinician is getting the biopsy using a fine needle aspiration or FNA, then in many cases you're really limited. You just have cells and some fluid. In other cases, you may be using a core needle biopsy by radiologists, and in that case you get more tissue. But these were some of the challenges that we identified. Number one, there was a lack of standardization among radiologists and pulmonologists performing biopsies. And a big part of that was because many of these clinicians were in private practice, and so they didn't necessarily communicate, collaborate, or even follow a standard operating procedure as a specialty group per se. Each individual sort of had his or her own way of performing biopsies. The second was regarding the training that pulmonologists and others underwent to use some of these more advanced bronchoscopy techniques, specifically endobronchial ultrasound or EBUS. In some rare cases, some of these programs also had navigational bronchoscopy. And then there was the issue of the on-site evaluation by a pathologist or a cytotechnician. When the physician is performing the biopsy, is there enough tissue? And can someone actually say, yes, you've got a good sample here, or you know what, there's not enough here, we need to get a few more samples. So we found that these were some common themes. We had the opportunity when we conducted these learning labs to talk to each program and to see, you know, how can we overcome some of these barriers. And at this point I want to say, you know, Gail, do you have comments in terms of your own program as to these issues? You know, were these issues that also resonated at your center, and if so, what was being done?
Okay, so just let me back up a little bit and just talk a little bit. I'm in a small community hospital on Long Island, and when we started the we have a small program, and we did have a lot of these problems. So what we decided, first of all, to start the whole program was, if any of you are certified by the American College of Surgeons, we established in our cancer committee a clinical goal, and one of our goals was to establish a program to look at biomarkers. And one of the first problems we did have, as Joe was speaking about, is we did have a problem with our fine needle aspirates. And we have very few people in our program that actually do the biopsies. We actually have an interventional radiologist. Most of our pulmonologists, none of our pulmonologists do any of the biopsies, and we also have a thoracic surgeon who does the biopsies too. And it was established very early on that the pathology did not want to take fine needle aspirates. They preferred all core needle biopsies, percutaneous cores. So we know we can do the fine needle aspirates and get tissue blocks, but at Huntington, where I am, we didn't accept them. And so that our interventional radiologists and our thoracic surgeons are very clear that we need core biopsies in order to get enough tissue so that we can send them for the molecular markers. So that kind of took away the problem right away. And as I said, our pulmonologists don't do the biopsies. It's really left up to 2 or 3 people in our institution that do it. And it really was designed by our pathologists, who said that they would only accept the cores because they knew they could get enough tissue from the cores as opposed to the fine needle aspirates.
I appreciate that comment. Yeah, I think that's a great example of also when we went around to these 8 programs that there were different dynamics as to who were the clinicians performing most of these biopsies and who decides, should it be done by a pulmonologist, should it be done by a radiologist, or by a surgeon. And I think what we're finding more and more is that there are certain programs like yours, Gail, where there's a very clearly established pathway in terms of how these suspicious lung nodules or masses are biopsied. And in many other places, it's really determined by either a primary care clinician, an emergency room physician, perhaps an internal medicine physician, or a hospitalist who decides, hey, based on the location or based on who I know, I think this should be biopsied by a pulmonologist or this should be biopsied by a radiologist. We also found other programs where every suspicious lung mass gets evaluated with a pulmonology consult, and then it's ultimately up to the pulmonologist to decide who should perform the biopsy. And ideally, I think you get sort of a tumor board scenario where you have the interdisciplinary team talking about, based on the location, the size, and other criteria, how it should get biopsied. But the reality is that in the community, so many of these human resources, in terms of the expertise, the equipment, even access to the endoscopy suite or the operating room, might be limited, and so some of these programs are really just doing the best that they can to get these biopsies performed as promptly as possible. But of course, at the end of the day, recognizing that the tissue quantity is becoming such a challenge today in today's era of molecular testing, because back when all you needed was enough tissue to perform a diagnosis and just to be able to say that yes, this is cancer, or no, it's not cancer, you only perhaps needed a very small amount. But today, because of the need for these biomarker tests, we need more. Now, it's not tremendously more, but it is definitely more. And so this was definitely an issue. And we'll come back to this as well, but let me just move on because,
so
yes.
Can I jump in there too? I just want to also say that even though we have a small program, the other thing that I didn't mention was we have a program called MTOP, which is Multidisciplinary Thoracic Oncology Program here, which meets once a week. And it is a lung program where all the prospective cases are presented, and it is multidisciplinary. We have the pulmonologist, we have the interventional radiologist, and we have the surgeon there. And the cases are presented, and at that time they try to make a decision on who would be the best to biopsy. Would it be better to go with interventional radiology, or is it central lesion that we do navigational bronchoscopy here? Would we do better to do it that way? The other thing that we also do, since we don't take the fine needle aspirates, is that all percutaneous cores are intraoperatively, there's a touch prep done, and they're told by the pathologist if there's enough, if they're cellular enough, and if they also correspond to the picture. So they have that also as kind of a fallback for them to make sure they're getting enough tissue and they're getting the right amount of tissue.
Great, and I appreciate that. And we are going to be, like I said, coming back to some of these issues too, because here we're addressing some of the barriers, and then we will talk about the improvement plans that some of these 8 programs made. And then, of course, there are great examples like the one that you just shared. So another barrier that came up over and over was that these biomarker tests were either delayed or they were not being ordered for patients who potentially were eligible, where that information would then guide treatment decisions. They were delayed in some cases because the biopsy gets done, say, on June 1. Then the medical oncologist sees the patient, perhaps a week or 2 later. And then at that point, the medical oncologist sees, okay, this is advanced lung cancer, so let's send it off for EGFR and ALK. And then it may take another 2 or 3 weeks for that information to come back. And what we found over and over was that there seemed to be universal consensus that when the diagnosis is established by the pathologist, and if we know that this is advanced adenocarcinoma of the lung, that it should immediately go off for EGFR and ALK testing. And so these were the issues, we wanted to understand in the community setting. Are there pathways? Are there ways that the pathologist can enable that testing in either a reflexive process, a pathology-driven reflexive process, or does the pathologist have that open line of communication to know which oncologist to speak with and to say that I have this patient who's got this stage 4 adenocarcinoma of the lung, I really think that we should send it off for EGFR and ALK testing based on guideline recommendations. And what we found, once again, across all 8 centers was that there were a lot of different processes in place, different forms of communication, different standards and expectations. And we wanted to see, if physicians are forgetting to order the test or if it's taking too long, are there ways to reduce that delay? We also wanted to see that, if patients were being diagnosed as inpatients and they were still in the hospital, do hospitals actually have a policy in place to address the Medicare 14-day rule, where if that test is performed, if the molecular test is performed while the patient is still hospitalized, then Medicare won't reimburse for the biomarker testing. The hospital would have to wait till the patient gets discharged, wait 14 days, and then at that point send the specimen off for the molecular test in order to get reimbursed. So were there ways for hospitals to potentially deal with these issues, or were they handling it from a case-by-case situation, and were these patients, once again, potentially experiencing delays in treatment? And then, of course, there were confusion, controversial issues regarding, for instance, the issue of staging. You get this lung biopsy, and then you know that it's lung adenocarcinoma, but you haven't staged the patient yet. So do you wait to stage them before you perform the molecular test, or are there ways to find efficiencies there? And then, of course, the controversies around which molecular tests to order, and should they be sequential, should they be simultaneous, as I mentioned earlier. We found, once again, differing attitudes amongst the medical oncologists in the community, some who I think are much more driven to identify patients for clinical studies, wanted to test for broader biomarkers so that if they identified a mutation, then they could then refer that patient for a study. But we know that in the sort of community setting, on average, 2 to 3% of patients are really the only ones who get enrolled to clinical studies. So if these medical oncologists are primarily just going to deliver the standard of care and go based on EGFR and ALK testing, then was that happening in a timely fashion? So once again, Gail, any comments on these issues as it pertains to your program and some of the things that you've been hearing about from your clinicians?
As far as the physician forgets to order the test, we did initially have that as a problem. The physician, the oncologist wouldn't order it, not the oncologist, the pulmonologist wouldn't order it, the interventionalist, and even the pathologist. But we now have it so that reflexively all our stage 4 lung cancers are ordered for EGFR and the ALK testing, and they don't actually have to wait. They just know if they're advanced adenocarcinoma, they will order it. The 14-day rule has still been problematic for us, although we have discussed it. And I know when we had some of our seminars ourselves that we actually talked about that there are some facilities that just send it out and don't pay attention to the 14-day rule. But that kind of becomes a financial issue for a lot of these hospitals, which are under a lot of pressures to begin with. So right now here at Huntington, we are still doing the 14-day rule and waiting until the patient is discharged. Unless the physician feels it's a matter of, really great urgency, will they speak to the pathologist on an individual basis to see if they can bypass that at all. But then it becomes you get talking with your finance people too. So we still abide by that. And as far as waiting for tumor staging, we pretty much do wait to know that this is advanced lung cancer before we order the molecular testing. We don't test it on everybody, stage 1, 2, and 3, and 4. And as far as what test to order, we do order the EGFR and we do the ALK.
Mm-hmm. Yeah, and I think, what we also found regarding the inpatient rule and the CMS 14-day barrier was that in most of these community settings, the number of patients who are getting diagnosed as inpatients was fairly small. Most of these tests are being performed as outpatients. So we're talking, at the end of the day, in most of these scenarios, a very small number of patients. But regardless, issues that every program, I think, is dealing with, and I'm sure is going to continue to evolve, especially in the landscape of lung cancer screening that we're in today. So I want to just spend a few minutes now talking about some of the improvement plans that amongst these 8 programs that participated in these learning labs, they collectively came up with. And I think all of them universally agreed that there needs to be strong leadership, particularly given that this is not only an interprofessional and interdisciplinary issue, but that in different cancer programs around the country, the leadership as well as the structure of these different physician groups and the levels of autonomy versus staffing and everything else, those dynamics all need to come to play in order for processes to be smooth and to be efficient. And so to establish protocols and pathways and to have consensus from all the different stakeholders really needed that level of leadership. The other point was on education and training, because not only around the biopsy methods, for instance, to get all the pulmonologists together and to make sure that they're doing the biopsies in the most optimal way, or in other examples, to get all the radiologists together and to have them all share, how are you doing your lung biopsy and this is how I'm doing it, and can we establish consensus? But there was also the opportunity to train and educate the non-oncologists about the importance of biomarker testing for lung cancer, because most of the pulmonologists and radiologists and others are not really staying up to date on all of these latest advances on the medical management of patients with advanced lung cancer. So for them to hear about things like EGFR and ALK testing and some of these other biomarkers is still fairly new for them, and it's an evolving area. So there was definitely room for education. Those that didn't have the kind of pathology resources, we did have them explore either telepathology or, establishing some form of rapid on-site evaluation by either a site of technician or others. But every center, once again, keeping in mind that some are large and well-staffed and some are more limited, had to sort of deal with and prioritize for themselves, which of these changes will ultimately lead to the greatest improvement. And for some, it was developing policies or reflexive testing pathways. In others, it was to develop subcommittees or other groups within their cancer committee that could establish some guidelines so that to minimize the level of deviation that was occurring or those sort of special requests that perhaps were being made for additional testing. And then ultimately the tissue handling procedures amongst not only the pathologists, but those working in the pathology departments, receiving the requisition forms and even transporting the tissue. Were there ways that some of these things could be optimized? So these were some things, I know, Gail, that you've touched upon some of these already, but did you want to add anything else here?
Okay, just a few things that we've done here is we now do, which we didn't do originally, is we now do navigational bronchoscopy. And what I've learned about navigational bronchoscopy as a means of getting tissue sampling is that there is quite a steep learning curve, and we're getting better at it. But those are the two main methods that we're using is navigational bronchoscopy, and we're also using percutaneous biopsies. The other thing that I find, and I've talked about this before, is really important is the ongoing education that Dr. Kim referred to. I find, being that I am a nurse, is that as far as the biomarkers, and I know this is not what this is all about, but I find that a lot of the nurses who will be talking to the patients, and Dr. Kim is right, a lot of even our primary care doctors are not aware about these biomarkers and how important it is for us to be more educated about it, because our patients are starting to ask about it. What does an EGFR mean? What does it mean to have an ALK testing? How is that going to impact on me and the medications that I'm going to take and that kind of thing? So I think that's been one of my very important goals here, is how am I educating part of the staff that I'm working with, and even some of the doctors that I speak to that don't even know what I'm talking about when I talk about these biomarkers. And knowing that, biomarkers and genetics and all that's very new for a lot of these people. But I think it's important because I think it's going to be important for our patients to understand why we do what we do. And I guess that's, I don't know, is that enough?
Yeah, that's a great point, especially, we all recently heard, the president announce the precision medicine initiative, and, whether in your region you're talking precision medicine, there's definitely a greater awareness amongst patients, their family members, and others about these various targeted approaches to disease. And so I think those are all excellent points. And let me just also mention here that when we went to these different programs in the country, and talked with them and performed these learning labs and really engaged the entire team, there were a lot of different levels of attitudes around this whole idea of continuous quality improvement or continuous QI. I think every hospital has a patient safety department, and that's usually where quality improvement also resides. And then a lot of hospitals also have a continuing medical education or CE department as well, but often those two are very separate and distinct. And what we found was that by having these learning labs in an interdisciplinary, cross-professional setting, and allowing them to see that these changes will ultimately lead to improvements in processes and efficiencies, but it also will improve patient outcomes and patient care. And it may not be a patient safety issue per se. This isn't necessarily being driven by a near miss or a medical error, but these are all changes that are going to allow programs to be more proactive in the changing landscape of precision medicine. So we talked about this, and there was really a greater, I guess, a level of engagement and really acceptance of this culture change towards continuous QI. And I think every program, even after we left the learning labs and followed up with them 3 months later, they were really wanting to know, all right, well, how are we doing with lung sample biopsies? You know, are they adequate? And how can we apply this to other tumor types beyond lung cancer? They also really evaluated and scrutinized their internal level of communication. Perhaps in the past, communication sort of was whatever was easiest and most efficient, but not as personalized. So there was definitely a greater level of engagement with communicating and making sure that they were using appropriate technologies that were all secure, HIPAA compliant, and so forth, if they were electronic communication technologies. There was opportunity to just educate them about simple process improvement methodologies, whether it was the use of the Plan, Do, Study, Act or PDSA cycle, or even introducing them to some basic Lean and Six Sigma methodologies. But most of these clinicians had not really had any kind of formal training or certification in process improvement science, so there was an opportunity at least to introduce those things to them. And to mention that we are living in an era where, because of the whole value-based healthcare and the need for improvement, that these are some of the metrics that will ultimately impact reimbursement down the road for both individual clinicians and hospitals as well. So as they identified the projects and changes that were going to be highest priority for them, every center sort of committed to those, and then we followed up at 3, 6, and 9 months just to see, how are they really doing, and how is that really impacting their patient outcomes. Gail, I just wanted to know if you wanted to make any mentions about the culture of continuous QI in your organization or some of these other comments here.
One thing, Dr. Kim, that I think is important is I agree with you. A lot of the physicians, even that I work with, even though quality improvement is becoming more and more important, and obviously if you're certified by the Commission on Cancer, they're looking for quality initiatives to do. And I think a lot of our physicians are not where they should be, but by just getting involved in the projects right now with biomarkers, we're actually starting to look at different quality improvement studies that we should be doing and could be doing. But we're not where we should be, and we're working towards that.
Yeah, and I think there's definitely been a lot of push from different national societies. For instance, the American Society of Clinical Oncology, or ASCO, has their COPI initiative for oncology practices, and they can get certified. And what we found across these 8 programs, some of them had oncology practice that had gone through that process of getting COPI certified, and there are certainly a number of others, but it's, like you said, it's definitely an evolving area right now. Just a quick comment about some educational resources out there for those on the line. The Pulmonology Society, the American College of Chest Physicians, actually offers a performance improvement module on EBUS endobronchial ultrasound, as well as a transbronchial needle aspiration, and you can find that on the chestnet.org website. And then for interventional radiologists, they also published a quality QI guidelines for needle biopsy that's available on their society journal as well. And we are, as we mentioned earlier, certainly in an era where biomarker-driven therapies, clinical trials, there's not only greater awareness, but I think even in the community setting, more and more is being pushed in this direction. We also know that lung cancer screening has either launched or is launching, or in some places they're getting ready to launch. So that's going to bring in even more patients into the mix, and the evaluation of that suspicious lung nodule or lung mass is something that has to follow a specific pathway that every center has to determine what makes the most sense for them. The treatment guidelines around biomarker testing is a moving target, and right now we are living in the era of EGFR and ALK approved FDA therapies, but I'm sure in the next year, 2, 3, that's going to continue to evolve. And then, of course, the reimbursement models that we talked about regarding accountability and value. So we know that as it relates to this whole area, there will continue to be changes, and it's an evolving area. What I would encourage each person on the line to consider is for your own program, what are the issues that you're dealing with, and what kind of patients are you treating, and how can process improvement methodologies change and essentially improve the management of these patients. And so with that, I want to just sort of spend a moment and just, we do have some questions that have come in, so I do want to address some of these. And meanwhile, I also just want to mention that on the ACCC website under Provider Resources, there is an upcoming ongoing advances and improvements in molecular testing that will be mailed out with the July and August Oncology Issues Journal. And you can certainly find a number of other references to these projects on the ACCC website. But let me go ahead and just dive into some of these programs. So, Gail, you mentioned in terms of the different types of biopsies, percutaneous as well as navigational bronch. How has your program changed either the pathways or developed the process on how patients are going to get biopsied if they undergo lung cancer screening and they have a really small suspicious nodule? Can you comment on that?
Well, we don't do lung screening yet, but we will be doing it in the near future. And I'm assuming that the way we do everything else, we don't have a nodule program like some programs have nodules and they look at all the, well, I shouldn't even get into that, but I think what's probably going to happen is that we're probably going to do them prospectively, like we do all our MTOP. We're supposed to present every one of our cases that we are suspicious, and even the small ones, and make decisions on whether they need to be biopsied or not biopsied, and how do they have to be biopsied.
Okay. And can you, another question that came in was just regarding the level of, I guess, sort of collaboration and working dynamics between your oncologists, your pathologists. Can you just make a comment as to, are your oncologists, is it primarily just one medical oncology group? Are there a lot of independent oncologists? How do they, what kind of relationship do they have with the pathologists in your organization, and how has that evolved?
Well, we have 3 different groups, and we have 5 oncologists that serve our hospital, and they're all with different health systems too, unfortunately. But they do have a relationship when they send the tissues over to our hospital to be under pathology. That they do have a working relationship. We have 5 pathologists, and they do speak to them individually if there is any concerns or any questions about their pathology report. So I don't know that there's any problem, and they're certainly accessible. Our chief of pathology is very interested in biomarkers and genetics, and he's really one of the founding members for the whole program, because he and one of our chief oncologists established this program and review on a regular basis, the new biomarkers that are improved in that kind of issue. But I don't know that there's any issues with them, and all 5 of our oncologists have a good working relationship with all 5 of our pathologists.
And are your pathologists all in a single group, or are they all also in different groups?
No, our pathologists just work for the hospital. It's a community hospital, and they all work for the hospital, employed by our hospital. Okay.
All right. And I guess the other question that came up is regarding just this whole molecular and biomarker testing as it relates to lung cancer. What other changes, whether it's in processes or communication or policies, do you envision potentially in the next 6, 9, 12 months in your program?
Well, the one thing, doctors hear about new biomarkers that are coming out, and we should be testing for them. And what happens is our pathologists and our oncology, we actually have 3 members of our little subcommittee, actually meet on a regular basis and decide what ones will be ordered reflexively and what won't be. I know it's not a lung one, but like MSI for colon cancer. We've now determined that all our patients that have colon cancer will be tested for MSI, but that was an agreement that was made out of evidence-based medicine, that it is an approved one. So I think I see that as new markers are coming to the fore, that I'm going to see more and more of our doctors looking at what the evidence is and then starting to order those kind of things.
Okay, great. And just one other question that seems to, or that has come up in is really around this whole issue of value and reimbursement. And are there comments that you can make regarding some of the either challenges or changes that your program is considering or adopting to put a greater focus on value and accountability and those kinds of issues as it relates to lung cancer management?
Are you talking about the ordering, I guess the ordering of the biomarkers and ordering them?
Yeah, I think just overall, including from the testing process to the ordering process to even choosing of the treatments and sort of that whole management process.
You know, the only thing that, you know, I have brought up, because I'm, is the 14-day rule, and a lot of our doctors have brought that up, that it seems to be onerous for some of our patients. And you're right, that very few of them are diagnosed as inpatients, and mostly it's an outpatient. But when you get inpatients that have stage 4 lung cancer, that becomes a problem. And we have talked about how can we make it so that people aren't waiting 14 days to get an answer of, you know, whether they're EGFR or ALK positive. So that's really about the only thing that I can really comment on.
Okay, great. Well, those are all the questions that we have. So once again, I want to thank everyone for joining us in today's webinar, Molecular Testing, the Tissue Issue, Sampling and Testing. And as a reminder, funding and support for this series is provided by Pfizer Oncology. And there are a number of resources that are available on the ACCC website under Provider Resources, as well as keep your eyes open for the upcoming ongoing advances and improvements in molecular testing that will be mailed out with the July and August issue of Oncology Issues. I want to thank Gail for joining us today, and thank you all for joining us on the webinar, and we hope that you have a great rest of the day. This now concludes the webinar.